Hello everyone, welcome to the third episode of Pathologue. Today with me I have Dr. Nanditha Sujir from Oral Medicine and Radiology Department, and we are going to have a dialogue on pericoronal radiolucencies. Welcome Dr. Nanditha.
Thank you Dr. Srikant.
To begin with, what do you mean by pericoronal radiolucency?
This term is a radiological descriptor that is used to describe a radiolucency that surrounds the crown of a tooth. Now, generally, we see follicular space around an impacted or an erupting tooth. Can you shed some light over the pathogenesis of such a radiolucency, sir?
Yes, sure. As you say, the description is a pericoronal radiolucency around the crown of a tooth. At the last stage of tooth development, the crown of the tooth is surrounded by reduced enamel epithelium, which is a thin two-cell-lined epithelial lining. During the eruption, the eruptive forces initiate some amount of inflammatory changes, and because of the changes in the hemodynamic and osmotic pressure, fluid gets accumulated either within the follicular space or between the follicular space and the tooth. This gives rise to this kind of pericoronal radiolucency. So can you tell me which are the common teeth which are involved with this kind of radiolucency?
Generally, pericoronal radiolucencies are associated with impacted teeth. So our usual suspects are the impacted third molars, especially the mandibular third molar. Also is the maxillary canines, and also any other impacted supernumerary tooth can have a pericoronal radiolucency.
Alright. So most of the time, how does the patient present to you and how do you detect such a lesion?
Generally, a small pericoronal radiolucency is usually asymptomatic. So the patient can present with any routine complaint, and we detect it as an incidental finding on a radiograph.
Okay.
Apart from that, the patient may be concerned regarding the missing tooth, so that could be the complaint as well.
Okay.
So generally, it's an incidental finding.
Alright. So what are your common differential diagnoses?
Usually, the most common differential diagnosis is hypoplastic follicular space, dentigerous cyst, unicystic ameloblastoma, adenomatoid odontogenic tumor, calcifying odontogenic cyst, and keratocystic odontogenic tumor.
Alright, so how do these present clinically? What are the clinical features?
Again, clinically, if it is asymptomatic, we may not see many features, but a larger size tumor or a condition can cause facial asymmetry and cortical expansion. If they are secondarily infected, we can see pain and some amount of pus discharge associated with it. For this differential diagnosis to come to a final diagnosis, we usually need histopathological support. So, Dr. Srikant, can you elaborate a little on the histopathological findings of these conditions?
Sure. Let me describe the most common differential, that is dentigerous cyst versus the follicular space. These two entities are very similar histopathologically. They have a very thin reduced enamel epithelial-like lining supported by a very loose connective tissue stroma. This connective tissue stroma may have some odontogenic cell rests, which are nothing but cell rests of serrate, which is the end product of the dental lamina. This may show some amount of calcifications or may show some stimulatory growth processes also. When these entities are stimulated beyond a particular time period, it may also transform into a small tumor like an unicystic ameloblastoma, a follicular ameloblastoma, or adenomatoid odontogenic tumor. You can also have a cystic neoplasm like that of a calcifying cystic odontogenic tumor. When it comes to unicystic ameloblastoma, you will have the typical ameloblast-like tall columnar cells that may be seen. And in case of calcifying cystic odontogenic tumors, you may have a lot of ghost cells that may be visualized. In case of AOT, you will have the typical rosette patterns that can be visualized histopathologically. So it is a dead giveaway of differential diagnosis. When it comes to keratocystic odontogenic tumor, we need to be really careful with the diagnosis because keratocystic odontogenic tumor radiologically may resemble a dentigerous cyst, but histologically is known to be more aggressive than that. It will have a very typical 6 to 8 cell thick keratinized lining with the basal cells exhibiting palisading and also presence of lot of daughter cysts.
Dr. Srikant, typically, how do you receive the specimen with pericoronal radiolucency?
Yes, I am sure following your diagnosis radiologically, the surgeon would generally excise the whole specimen in toto. Overall, we receive specimen as the tooth along with the soft tissues attached. We would like to receive a specimen which has the soft tissue attached to the neck of the tooth, which is absolutely essential for us.
What is your ideal specimen and why?
The most ideal specimen would be to have the cemento-enamel junction attached to the soft tissue intact. The reason being, when it comes to dentigerous cyst, the attachment is typically at the cemento-enamel junction. So until and unless we see histologically the junction between these points, we do not define it as dentigerous cyst. Odontogenic keratocyst, adenomatoid odontogenic tumor, unicystic ameloblastoma do not follow this rule of attachment at the cemento-enamel junction. They may be much more deeper placed on the cementum surface or maybe coronally placed also. Hence, my ideal specimen would be an intact tooth with the soft tissue attached at the cemento-enamel junction. Now, when we are discussing, I would like to ask your opinion on how do you differentiate between follicular space and dentigerous cyst, because both of them histologically resemble.
So on the radiograph, we generally go by size of the pericoronal radiolucency. According to White and Furrow, the most recent edition, it says that an ideal follicular space is around 2 to 3 mm, and any pericoronal radiolucency that is above 5 mm is generally said to be pathologic or considered as a dentigerous cyst. So that is how we differentiate between a follicular space and a dentigerous cyst.
Thank you, Dr. Nanditha. That concludes this small discussion on pericoronal radiolucencies. I hope you were able to understand the concept of pericoronal radiolucency, the most common teeth involved, the differential diagnosis, the clinical features, as well as the histological features of the differential diagnosis. Thank you.
Thank you.